Hey, David Jaillet. This is the SOT basic 8 steps. The first one, we're going to be doing distortion analysis. It's going to be at a lateral view of my patient. I'm using his acromion as a reference point. I'll put my thumb on it, and I'm assessing for A to P sway, as we can see here. So A to P sway greater of 1/4 inch, that's category 1. And now I'll have my patient face the window. This time we'll do the SC tubercle, and we're assessing for lateral sway greater of 1/4 inch. That's we're thinking category 2. And now if my patient just had an antalgic lean and wasn't swaying and a muscle guarding, we're thinking category 3. Alright, so next we're going to be doing the first rib analysis. I'm going to start by palpating both rib heads of the first rib of my patient. Alright, once I have that, I'm going to have them flex and extend their neck. Do that 3 to 4 times. And I'm trying to feel for movement of the rib heads. Alright, you're good. Too much movement on both of them, that'd be thinking category 1. If one side's moving greater than the other, I'm thinking category 2. And if both sides aren't moving due to muscle guarding, I'm thinking category 3. Alright, so now we're on to step 3 of the preliminary test, and we're going to be doing cervical indicators. I'm going to be palpating my patient's cervical spine, and we're going to be also using the Lovett brothers relationship, correlating cervical spine to lumbar possible subluxations. Category 1 would be bilateral lamina tenderness on C3. Category 2 would be left lamina tenderness on C4. And category 3 would either be tenderness on any of the spinous processes of the cervicals, would be correlated to that lumbar TVP inferiority, and then cervical TVP tenderness would be related to lumbar spinous rotation. Alright, now we're going to be moving on to step 4 of the preliminary test, and we're doing cervical compaction. So first, I'm going to have the patient place their hands on their stomach and lift their head slightly off the table, and I'm going to have them raise their both legs 18 to 24 inches, noting the ease of movement. And now I'm going to be placing my thenars on both sides of the sagittal suture, pushing down P to A, and asking the patient to lift both legs again, noting the ease of movement. And which one? How was that?
It's harder.
Okay. For this video purposes, we'll say it was easier, because if it's harder, we're thinking lumbopelvic region as a subluxation, making it easier doing the cervical compaction. We're looking at a cervical subluxation. So with that, we're going to be doing the cervical stair step now. I'm going to be placing his head up, and I'm just stair stepping up the whole time. The first one is T1 and C7. Step 3 would be C6, C5. Step 2 would be C4, C3, and step 1 would be C1, C2, C1. If I find it a glide where it's supposed to lock in the first one, I'm going to adjust the anterior T1 to T4 and then do this figure 8. But if I find it glide where it's supposed to lock in any of the other steps, I do the figure 8 and then I reassess. Okay, so now we're moving on to step 5 of the preliminary test. We're going to be starting with basic 1. So I'm going to be placing both of my hands, both 4 fingertips, lining from the EOP to both mastoids. And what I'm feeling for, it's a very light pressure, but I'm feeling for pulsing of these muscles. And it's at first going to feel like a popcorn, non-synchronous, non-rhythmic feel. And I'm just applying this pressure till I feel them going rhythm. And now for Cat 3 Basic 3, I'm going to be doing opposing thumbs on the sagittal suture, and I'm going to be spreading it apart while I'm having my fingertips on the parietal, the lip of the parietal bone, and lifting up while the patient's inhaling. So take a deep breath in, Joe. We'll do that. And as he exhales, we just relax it down. And then we do that for 3 cycles. And that's the Cat 3 Basic 3. So now we're going to be doing step 6 of the preliminary test of corrections, which is psoas. So first I'm going to have the patient raise both their arms, and I'm going to have my feet shoulder width apart and pulling both of his arms back. I'm going to be placing his hands together, not looking at him, and I'm going to be bringing them in evenly. And then I will say his right is slightly longer than the left, so we're thinking his left psoas could be the problem. And so we're going to be having him lift his left knee. You can place your arms down now. And could you locate your belly button for me? And then be going in there, applying that pressure to the psoas. Yeah, I'm going to be standing on the contralateral side of my patient too. And once I get it in there, I'll be having that pressure. I'm going to have to the patient take a deep breath in, applying the pressure. And then when he exhales, I'm going to be closing the gate. Inhale again, keeping pressure. Exhale. Good job. And we'll do that up to 3 to 4 times. And now we'll come back and recheck by the patient placing their arms up again. Be pulling them back, placing them together. And oh, they're even now. Brilliant. It worked. So now we're on step 7 of the preliminary testing, and this is the anterior iliofemoral ligament test. So I'm going to be starting by grabbing proximal to the ankles and be inverting the whole leg, noting which side has more movement and which one's more restricted. So this left has a little more, we'll say it's a little more restricted on the right. And so to do that, I'm going to go to the contralateral side of my patient. And I'm going to be, would you put your left foot, right foot in for me? Be doing inch superior, inch posterior to the greater trochanter. And I'm going to be applying P to A pressure while the patient rotates his foot out slowly. Good job. Do it again. Good job. And on this last one, on the count of 3, I'll have you rotate it out as quickly as you could. 1, 2, 3. And I'd make an impulse on that. And then that's how you test, check, and correct the anterior iliofemoral. Alright, this is the final and last step of the preliminary testing, and this is the arm fossa test. So first we're going to be getting a muscle test, which Jaillet uses kind of like a lat or deltoid, he called it. So we're going to be having the patient keep their elbow fully extended, soft palm, and we're going to ask the patient to pull their thumb to the wall behind you. Alright, do that. Good job. And we can always make sure it's a good muscle by doing autogetic inhibition, but we don't have to. So now I'm going to ask the patient to locate their pubic symphysis. Alright, now I'm going to locate their ASIS. Okay, good job. I'm going to keep flat 4 fingers along the inguinal ligament. And then I'm going to muscle test again. Pull against the wall, good job. Now move down. Up, pull against the wall, good job. Then I'm going to rotate sides. Could you locate your pubic symphysis again for me, please, patient? The ASIS, flat 4 fingers. Pull against the wall. Good job. Move down again. Pull against the wall. And since all these tests are strong, this wouldn't be a category 2. But if any one of the 4 quadrants I tested went weak or change in muscle strength, we would know it's a category 2.